Let's jump right into the highest yield pediatric cardiology concepts for Step 2 CK. We're starting with the immediate clinical triage of neonatal cyanosis. The very first thing you need to do is distinguish benign peripheral cyanosis from life-threatening central cyanosis. If you see peripheral cyanosis, but the oxygen saturation is completely normal, you can simply reassure the parents. But if you're looking at central cyanosis, meaning mucosal or diffuse cyanosis with low oxygen saturation, you have to act fast.
So what is your next best step? You assess oxygen saturation and run a hyperoxia test using 100% oxygen. If the saturation actually improves, you're likely dealing with a pulmonary pathology, so you'll want to support ventilation and oxygenation. But if that saturation fails to improve, or if the infant is completely unstable, you have to suspect cardiac disease with a right-to-left shunt. In this scenario, your immediate next step is giving prostaglandin E1.
Why prostaglandin E1? It is a life-saving medication because it maintains the patency of the ductus arteriosus. You see, in cyanotic congenital heart defects, blood flow to either the lungs or the systemic circulation relies entirely on keeping that ductus open. You administer PGE1 to stabilize the infant while you urgently get an echocardiogram and get pediatric cardiology involved.
For the boards, you want to systematically organize all congenital heart defects into 3 strict physiological buckets based on their shunt direction. First, left-to-right shunts. These cause cachepnea, poor feeding, sweating with feeds, and poor weight gain, all thanks to massive pulmonary overcirculation. Second, right-to-left lesions. These bypass the lungs, causing immediate cyanosis. And third, interrupted left-sided output. These defects cause severe pallor, shock, and profound acidosis exactly when that ductus closes.
Let's focus on those right-to-left shunting cyanotic lesions first. What's highly testable here is how reliably you can differentiate them using just a physical exam, specifically looking at the second heart sound and murmurs, alongside classic chest X-ray silhouettes.
Let's directly contrast 2 heavy hitters. Transposition of the great vessels presents with severe, early cyanosis, a single S2, and that classic egg-on-a-string narrow mediastinum on X-ray. Survival strictly requires mixing through an ASD, VSD, or PDA, so give PGE1 immediately and consider a balloon atrial septostomy. On the flip side, tetralogy of Fallot features a harsh pulmonic stenosis murmur, an overriding aorta, and a boot-shaped heart. It classically presents with cyanic TET spells that improve when the child is placed in a knee-chest position or squats.
Next up is tricuspid atresia. Here, an absent tricuspid valve completely blocks right-sided flow from the right atrium to the right ventricle, which drops pulmonary blood flow to almost nothing. The ECG is your major clue. It reflects a hypoplastic right ventricle with left axis deviation, and you'll see tall, peaked P waves due to a massively enlarged right atrium.
Rounding out the cyanotic lesions, watch out for total anomalous pulmonary venous return, or TAPVR. This presents with severe cyanosis and respiratory distress. If you get a question describing obstructed supracardiac TAPVR, look for pulmonary edema paired with a classic snowman sign on the X-ray. That unique shape is created by engorged supracardiac veins and the superior vena cava. Now, what if a newborn presents with cyanosis and respiratory distress, but you notice a lower post-ductal relative to pre-ductal oxygen saturation, plus a prominent S2? You should immediately diagnose persistent pulmonary hypertension of the newborn. This happens when high fetal pulmonary vascular resistance persists after birth, forcing a right-to-left shunt across a patent ductus arteriosus. Treat this with oxygenation, ventilation, and inhaled nitric oxide.
Let's shift gears to acyanotic left-to-right shunts. Unlike the cyanotic lesions, these primarily present with signs of high-output heart failure. Because blood shunts from the high-pressure left side, you get massive pulmonary overcirculation. Clinically, this looks like tachypnea, diaphoresis during feeding, and a failure to thrive.
The most common of these is the ventricular septal defect, or VSD. The crucial exam point here is the clinical difference based on size. Small VSDs are often completely asymptomatic. They create a really loud, harsh holosystolic murmur at the left lower sternal border. Most of these actually close spontaneously. Moderate to large VSDs, however, cause respiratory distress, cardiomegaly, poor growth, and a softer murmur that might include a diastolic rumble from increased mitral flow. You manage their symptoms with diuretics and surgically close significant defects.
For atrial septal defects, or ASDs, the classic hallmark is a fixed, widened split S2 throughout the respiratory cycle. These patients might not present until later in life with exercise intolerance or arrhythmias.
Then there's the patent ductus arteriosus, or PDA, which classically gives you a continuous machine-like murmur and bounding pulses. You typically close an isolated PDA with NSAID therapy, like indomethacin, in selected premature infants. But here is a massive warning. Never give indomethacin to a cyanotic newborn, whose open ductus is the only thing keeping them alive.
Our third major physiological category is interrupted left ventricular output. These defects present catastrophically. We're talking severe pallor, cardiogenic shock, and profound metabolic acidosis. And the timing is highly testable. This presentation hits exactly when the ductus arteriosus naturally closes, just a few days after birth.
A prime example is hypoplastic left heart syndrome. In HLS, the left ventricle is severely underdeveloped, the mitral valve is atretic, and the ascending aorta is abnormally narrow. These infants look fine at first, but days after birth, they present with tachypnea, poor perfusion, a single S2, and importantly, no murder. They crash into lethal cardiogenic shock the second the ductus closes. Your immediate next step? Administer PGE1.
Similarly, coarctation of the aorta involves a thickening of the tunica media in the aortic arch. Because of this stricture, the body has to compensate via collateral circulation. On a chest X-ray, this leaves testable clues: inferior rib notching from dilated intercostal arteries, and a classic 3 sign from post-stenotic dilation.
Clinically, you'll diagnose coarctation by finding upper extremity hypertension paired with weak lower extremity pulses, giving you a radial femoral delay. If this narrowing is severe in a neonate, it acts just like an interrupted left-sided lesion, causing neonatal shock. And again, those severe newborn cases require PGE1 immediately before any surgical repair. Finally, let's lock down pediatric murmur logic and a major cardiovascular complication, Kawasaki disease. For murmurs, use strict pattern recognition. An asymptomatic child with normal growth and a low-grade musical murmur that decreases with standing has a benign murmur. You just offer reassurance. But if the infant is sweating with feeds, or the murmur is harsh, grade 3 or higher, or persists with standing, it's pathologic. That demands an immediate ECG and echocardiogram. Switching gears to Kawasaki disease, watch for a fever lasting at least 5 days paired with mucocutaneous findings. The next best step is administering IVIG plus aspirin, along with an echocardiogram at diagnosis, and again 6 to 8 weeks later. Why? Because Kawasaki can cause coronary aneurysms that may thrombose and trigger a myocardial infarction. And one last exam tip: be sure to delay any live vaccines after administering that IVIG.